Okay, slides are there, so that's all that matters. Thank you, everyone. I feel very privileged and honored to be welcomed here today. As an original person who grew up in Ontario, I'm pleased to be back, and I still feel like I'm really getting the lay of the land of the FASD approach in this strategy, in this province, and I'm pleased also to hear that a strategy is coming shortly, because I've had the luxury of working in Alberta and BC, where that's really helped drive some growth in all areas of our work. Here's the real trick. You know what? First, it's that awful time of day where we really kind of all wish we were eating. And I do like numbers, not numbers to the extent of losing the narrative, and I feel like maybe we should switch the education and the justice talks next time. Going down. But what I want to ask on a more balanced note is a more serious question. It's going to involve standing up, participation. I'm a psychologist. Consent is voluntary. Participate if you like. Think for a minute. Do you know someone with FASD who's had contact or been impacted by the criminal justice system? If you have, stand up. Okay, so those are my numbers for today, right? And I do think it's a really important topic, and I'm pleased that we get to talk about it today, and I hope this will be useful for many of you. I come to FASD from kind of a straddled approach, where I have a lot of background in criminal offending, youth violence, thinking about prevention, risk management, and evaluating people who are in the justice system with all kinds of trajectories and pathways that shaped their arrival into the system. One of those pathways looks obviously to be like it's FASD, but we see a range of people. And then I have a lot of expertise also now over time in FASD in particular. When I come to a talk like this, where everybody's on the same page about FASD, the conversation is much easier. But sometimes we lose sight of the fact that when I go back to the justice and forensic conferences, I'm doing a hard sell. And I'm actually talking about why talk about prenatal alcohol exposure at all. Okay? So we're really privileged to be in that position. What I want to remind everyone here about is this kind of tension around fairness in the criminal justice system, because I think we're at this unique time in criminal justice policy with FASD, where some really important decisions are on the table that are going to shape the future of how FASD is addressed in justice. But the criminal justice system has got this idea that it's objective and fair and balanced and blind, and that there are enough protections in place that protect individuals' rights and autonomy against kind of this higher power of the state, right? We know that the government and the state has more power than anybody who's being investigated or prosecuted for a crime, but that we've got some rules in place, and as long as justice is blind, everything will be fair. I think this is really where some of the question and challenge comes in for folks with FASD. And as I talk to you today, some of the policy recommendations and decisions that are being made are trying to find the balance between addressing FASD in a unique way that takes the blindfold off to increase fairness while still being fair for everybody else in the system too, and equally responsive. So it's just kind of an image I want you to think about as we go through. I have learned how to make infographics. Which is very exciting. But let's talk about the scope of the problem here, right? We've heard about prevalence in Canada and North America. We think in the general population it ranges anywhere in terms of A or D from about 1% to 5%. We know that there are two kind of prospective case ascertainment type prevalence studies in correctional and forensic settings, and that's about it. So the evidence is very limited. The first in adult federal corrections found a prevalence of around 10%, and the second back in 1999 found a prevalence in an inpatient adolescent forensic mental health service of nearly 25%. So this is a real crisis. If we assume that these data are reliable and that future research that's coming out replicate these findings, the rate, that's 1 in 4 potential kids in a forensic inpatient unit who are not just exposed to alcohol prenatally, but meeting diagnostic criteria for FASD. So this is really a pandemic crisis, and I tend not to use language like that lightly. However, we really think our knowledge at this point is a tip of the iceberg, right? The problem with lots of the generalizations that I think are being made without data to drive some of our decisions is that we know we only see the tip of the iceberg, but under the iceberg could have all kinds of different shapes and depths and continuity. And we need data to know what the underneath piece of the iceberg actually looks like, rather than just assuming or making assumptions that it's going to follow some kind of expected course. So we need a lot more evidence, I think, in forensic mental health and injustice around FASD. We know that the scope and the impact of FASD in the criminal justice system is also quite high. One prevalence estimate that came out for the cost of FASD in Canadian corrections estimated, and this is surely an underestimate, over $370 million annually for folks just in corrections, not necessarily in community placements. Some of our best and oldest data dating back to Anne Streitsky's seminal work showed that 60% of over 400 adolescents and adults with FASD had been involved in the criminal justice system. We heard that number replicated today in terms of the early data from the Canadian Data Form Tracking Project, replicating that. That's exactly what we're seeing. One recent estimate looked at trying to estimate what the increased odds were of being in corrections as a young offender if you had FASD versus if you did not, and they were 19 times more likely in an average year to be incarcerated relative to a young person without FASD. And in my doctoral work, I looked at 50 youth in 2 provinces who had been diagnosed with FASD and had involvement in the criminal justice system, and those 50 kids alone had accrued 2,312 criminal charges on their records. We know that we have another tip of the iceberg phenomenon there in terms of all the sorts of things that are actually happening for them that aren't making it to an official record. So the numbers are really shocking and startling, and I hope, aside from the fact that they're a little bit depressing after that lovely last talk, they do kind of spur a call to action. And what I do know is that you guys might not like data, but I'm confident from clinical wisdom and from the numbers that you're putting out, some of your kids are not going to turn into my kids as a result of your program. And so we need to have that data to figure out how to avoid getting up on my slides, right? That's why we need it. And so you guys keep doing that, and you bring people in who like bean counting if you don't like doing it, because lots of us do enjoy adding these things up because it's really, really important work. We have a huge call for policy change right now nationally in Canada. We've had multiple, and in the United States, we've had multiple agreements and resolutions from the bar associations. We've had a national level consensus development conference around legal issues in FASD that was widely attended and resulted in a communication around the directions that we need to go. We've had not one but 2. There's an active current bill to amend the Criminal Code of Canada to include FASD. There's no other mental disorder codified into the Criminal Code of Canada. And we've had 2 bills trying to look at making change, or maybe unblinding justice a little bit, by actively writing into the criminal code, and had a full standing parliamentary committee report as a result of the first bill. And FASD, in particular FASD and justice for Indigenous people, was recognized in, I think, 3 recommendations in the TRC report last year. So there's sweeping recommendation for change. And really, the emphasis is the same emphasis we've already heard today. It's the same emphasis we've heard in the strategy. It's not surprising. It's increased access to assessment, diagnosis, consideration, both at sentencing and at every juncture through the criminal justice process of the disability, increased availability of interventions and supports throughout the process, but also in particular in community-based settings, so that we can get people supported and have the treatments and interventions they need outside of the justice system and avoid them coming back in. Because we have an FASD in justice, there's not a lot of good data establishing this, but a huge history of clinical wisdom that tells us we have a big revolving door phenomenon where they just cycle and cycle and cycle. If you look at 2,300 charges for 50 kids, I think that speaks to that phenomenon, right? So as I've said, this is really informed by significant clinical and experiential wisdom, but when we're making big decisions, I am a firm believer that they need to be rooted in evidence, not just numbers. Qualitative evidence is evidence as well, but it's done in a rigorous and structured and routine kind of collected way that's systematic. Without evidence, we have no way of knowing whether our programs are doing good, and sometimes more startlingly, we also have no way of knowing if they could be doing harm. So for instance, as a clinical psychologist in a forensic psychiatry program, I often evaluate people, and I'm asked to make recommendations to the court about what somebody's risk to engage in future offending or in violence in particular is, and what I think will help support their desistance from involvement in crime in terms of management strategies, treatment programs, what will help bring down that level of risk to help them stay out of trouble again in the future. I'm a big fan of assessment. You're going to hear me talk about it a lot, but if we codify a diagnosis into the criminal code and everybody starts coming through with assessments and lots of folks are coming through and I'm having to say these folks are really high risk, they've got really complicated risk and need profiles, but there aren't resources in the community to help support and appropriately manage those needs, you know where they're going to end up. And it feels really depressing as a clinician to be making these recommendations and not have an appropriate strategy to help support people that isn't jail. And so I think we need to think about, in a balanced way, what the evidence tells us, what we know, and what we need to know to make some of these decisions. So just briefly, what is this forensic psychiatry, forensic psychology thing? Basically, it's a whole group of clinicians who are trained both in legal issues, both civil and criminal, as well as mental health and addictions issues across the board and physical health issues. And we really help and support and help do treatment with folks who find themselves in the criminal justice system and have significant needs in those areas. But I routinely hear in my practice, I work in a hospital that actually has a 100 inpatient program and 100-person outpatient program for people with forensic mental health issues. And they're like, what's this FASD thing all about? Like, why does this matter? It's not considered in practice. They're actually still questioning why they should even kind of come to the talk. So I think we have a lot of work to do in terms of gaining the momentum, but also that has to be done in a balanced way. I think my introduction to Ontario is that I'm so impressed by the amount of advocacy that's been done to get this disability, and by FASD-ONE in particular, to get this disability, the recognition that it needs to begin to have the wheels on a plan to help divert adverse outcomes. And now comes the time for the shift to help get that advocacy into data and to building relationships and to try and get the change we need out of people doing the work and policymakers and politicians and physicians to actually go and do things differently. And it's a really interesting time to be working in the field, but I think it requires some balanced consideration. I'll back you guys up a little bit. I first became interested in FASD as a forensic psychologist because we're doing these evaluations all the time. So this is a small handful of the risk factors that we know based on good data about offending in general, not in FASD, but in the general population, where there's a huge wealth of data that tells us what factors are going to increase a person's chances of getting into trouble with the law or engaging in violence. This is a handful of them. Does it remind anybody of anything? Right? And so I thought, oh, okay. And at that point, years ago, there wasn't anything published on this. The question that I'm always mulling around in my mind and that I have lots of debates about and that I'm not clear on an answer yet is FASD overlapping with these risk factors and a little bit on its own? Is it something that's unique and completely on its own, and does it need its own complete unique approach to provision and to treatment and service? Or is it a risk factor, a really heavy, important risk factor that's like other risk factors? And we don't have good data to know the answer to that question, but it completely shapes the way that we implement policy and programming and spend dollars moving forward. And so that's where we need more information to really figure out how it actually ends up that people with FASD get into trouble. And I know we have a lot of clinical ideas about that. I certainly do, which is why I also have the hunch that some of those kids are not going to become some of my kids, but we need more data on that. We know that I think at one point in our early understanding and the way we talked about secondary disabilities, it was kind of like you have FASD and then you have secondary disabilities and it's kind of a linear progression. But we've heard already today the evidence is so complicated and nuanced in terms of all the factors that actually contribute to a person ending up experiencing adverse outcomes. And actually, this probably looks like a really crazy bidirectional, like back and forth, multi-feedback model, but my editing visual skills ended at one-way arrows. So it's just a really nuanced thing to consider. But I think with failing to identify the disability, I think what we're hearing, and invisible disability for many folks, can lead to significant miscarriages in justice at all points through the lifespan and in the criminal justice system, increases the risk for a revolving door problem in justice for people with a disability, and excessive adversity, especially later in the lifespan, based on the complex clinical needs and early experiences that folks have had that tend to go untreated. We don't even know what life looks like for folks after 40 with the disability. We know that 40-year-olds in the criminal justice system already look like 50-year-olds, and 50-year-olds look like 60-year-olds without this disability, because it's a hard life. The vulnerability factors that get you into the justice system and the way that the justice system kind of fails to manage addiction and health issues really contributes to early morbidity, but we don't have information on that in FASD yet. Some of the early data that we do have tells us, some of the work that I've been involved in is that young offenders with FASD have less understanding and appreciation of their rights at arrest, which increases the chances that they're going to make statements without understanding, the law and I was going to say Law and Human Behavior, that's a journal. Law and Order, you have the right to remain silent, that piece. It's lunchtime for me too. They don't understand and appreciate that they need to ask for rights when they're being interviewed by police. They don't understand and don't have the capacity to communicate and appreciate through the adjudicative process. It's incredibly complicated. Lots of us would struggle. I've tried to support family members who don't have a disability when a family member gets into the justice system, and the paperwork, even just to get bail, you have to have like a PhD degree to understand it, let alone when you actually are an individual without support and with a cognitive disability. So we have evidence showing that that's significantly decreased there. We have evidence that's coming that hopefully will get published shortly that shows that when we use the standardized approaches to risk assessment that we tend to use in forensic mental health, these folks are rated as being exceptionally high risk. And you just think back to that list, that checklist of things that we're concerned about that increase a person's risk, well, that kind of comes inherently in the disability. And we know, I don't know why I'm looking over there, I look down here, it's a bad habit. We know that there are exceptionally limited opportunities for assessment full stop as an adult or as an adolescent with FASD, let alone an assessment that is going to be able to take into consideration any of this nuanced, risk-related, prevention-related justice information. So the opportunities are very, very limited. There are some really exciting, excellent programs in Canada, particularly for adolescents, where the funding opportunities to have an assessment, coordinated assessment through the Youth Criminal Justice Act provide money for that kind of opportunity, but the same thing doesn't really exist for adults. I don't really need to talk about this today. I think you guys can appreciate this, but this is really just showing we have a group of people with significant cognitive disability, and on top of it, exceptionally high rates of early adversity, and that those two things are interacting. So you've got an exceptionally sensitized brain with significant prenatal adversity, and that person is going off into the world with limiting coping strategies, different biological processing of stress, and they are going into incredibly adverse environments. So it's not simply that they have prenatal alcohol exposure, but they just have these complex clinical experiences. So this is data from my dissertation looking at 50 young offenders with FASD and 50 without. And so the 50 without had also experienced significant adversity, but not at the same rates, not in the same dose as the young offenders with FASD. CFS care is Child and Family Service Care, so in Ontario, different name, but same thing. But you can just see these exceptionally high rates of early life adversity and really high rates of clinical needs. Comparable types of clinical needs, but again, in much higher dose and with much higher fatality or the potential for fatal outcomes. So we see I think the percentage was 60% had a suicide attempt, right? Which is just exceptionally alarming, and we weren't in northern communities, we were in cities, and that just, at psychiatric hospitalizations, overdose, we just see the real risk of harm and the cost to society, to individuals, and to families when these needs go unaddressed. And the criminal justice system isn't equipped to address these needs. They're a health-related need that needs a complex system of being addressed that jails are not able to do. This is data from NeuroDevNet, where we looked at a study trying to understand how prenatal alcohol exposure coupled with early life adversity had a physical impact kind of under the skin on the stress regulation system. And I just wanted to again highlight that these rates of adversity we're finding in all different samples, in all different walks of life in kids with the diagnosis at very, very high rates. You can see 86% of that sample had been in foster care. Half had had some experience of physical or sexual abuse. Their parents themselves were having a difficult time. And even in this young age sample, where I think the average is around 10, 20% had already had criminal justice system contact. And we can just expect that number to go up. Work from my dissertation, as I've mentioned, showed that I think, I can't remember what the exact percentage was, but over 45 out of the 50 kids had a high risk designation using some of the tools that we use to try to make those decisions, including high risk for engaging in future violence. And it was clear to me that we had a 1-year follow-up period. They also got into trouble more quickly and they reoffended more quickly. So they weren't having those needs addressed. The idea of doing a risk assessment is not to be punitive. People can be really fearful of having somebody undergo this type of evaluation. The goal is actually to understand what's causing somebody to get into trouble and what their needs are so that we can create a plan that can appropriately mitigate that risk and help them stay out of trouble. But without knowing enough about FASD and what will help create that plan, we end up with all these high-risk folks and no clear plans on how to help them. So that's really what that study showed. This is one of my favorite poems, and I feel like we need many more than one path diverging, if you're thinking about Robert Frost, in terms of how we're going to move forward in criminal justice. And I don't know that we know the answer, but there are lots of questions that I want addressed, and there are some clear barriers that I see. Certainly there are a lack of skilled forensic clinicians. We don't have a lot of people who understand both the process and the experiences of somebody going through the criminal justice system, as well as the unique neurocognitive deficits and behavioral challenges and experiences of people with FASD. We have a huge lack of diagnostic capacity, full stop, for folks with FASD, and a lack in justice of funded assessment mechanisms, so that even if we had a ton of clinicians trained in places on both the things, neither health in most places, nor justice, nor any other kind of governmental funding model really provides the opportunity for clinicians to do that work. So we need to put our thinking caps on in terms of how to actually fund evaluations. That also means we need to find a way to do evaluations that are cost effective and are really going to maximize how much time can we spend, how much time do we need to get a clear enough understanding to actually help a person so that we can help the most people possible. So how do we address the problem? I'm never entirely sure, but these are, I think, some of the areas that we're all thinking about. Nancy spoke earlier about feeling like the pregnancy tests in the bars were a little bit too far down the road, and I feel like we've gone on a world trip compared to that by this point. So the clear answer for a sustainable solution is to address the problem before somebody becomes entrenched in the criminal justice system. But we can't put all the money there because we have generations of people entrenched in the criminal justice system who are raising children we know who are at risk of becoming entrenched in the criminal justice system. So this is going to take many, many years to solve and still requires pretty significant attention. And I think in addressing all risk of criminal justice system involvement, it always comes back to, and we've already heard about today, really solving the social determinants of health. That's how people end up in the criminal justice system, is because they're not having all of their health and developmental needs met, and their families aren't, and their communities aren't. And I could talk about that for 10 days, so I won't. I'll just show you a picture. I wanted to share this slide because Sheila Burns feels very passionate about it, and I do think it kind of captures where we're going wrong. So we don't catch somebody when they're young. And then they don't have kind of early intervention to support their care environment, to really understand in an early stage what kind of disability-based education supports they need, for instance. Things start to go off track. They start to get frustrated. Their caregivers start to get frustrated. Care placements fall apart. They start to have increased contact with the justice system, with mental health problems, with other secondary disabilities. Then they get really complicated and confusing looking because they've got an intellectual disability, they've got trauma, they've got emotional problems, they've got behavioral difficulties, they get 10 diagnoses, they go on multiple medications. They kind of look like bad people to most clinicians by that point who are feeling burned out. And then they shift to a more punitive, restrictive, punishment-based view because no one knows what's left to do. And that's just not a sustainable approach, obviously. But it's a great kind of picture of where things can go awry if you don't catch them early. I do think there's an emerging literature because we tend to be doom and gloom and very risk focused in criminal justice because we're trying to stop people from violence, killing people, hurting people, significant costs to society and to other people, and preventing victimization. But as with all things, a strength-based approach has huge potential in places where you can't ameliorate deficits, right? Not only that, it's more palatable and rewarding for clinicians, and individuals are more likely to be able to engage and feel like they're actually being respected and given an opportunity to build some resilience. And so 2 studies have come out that were qualitative based on interviews of people who would actually have the diagnosis and been through or had contact with the criminal justice system. And hope, willingness to change, and resilience were reported to be important, along with what we know about early diagnosis, lower substance use. In our study, we showed that there was a direct link between recidivism risk and protective factors, and that tells us we need to fill up those buckets because we might get really good payoff that's easier to ameliorate than areas where there's pronounced deficit, to be able to kind of offset those things. And so what do we do for intervention? Again, I get the luxury of going after everybody who's gone before me. Most of these people right now are going unnoticed by virtue of not having any physical characteristics, ending up in that really dysregulated, complicated punishment-based cycle and being mistaken as bad people who are breaking the law on purpose. Certainly some are, but many are not. So we need reasonable, validated, empirically informed approaches to identifying people that work in big numbers. Jails are really busy, dangerous places, and if we're going to try to screen everybody at intake for a disability, it needs to be quick. It needs to be something people feel comfortable participating in, that's easy to train the intake workers on doing, and we just don't have really good data on that yet. As I've said, obviously we need increased assessment opportunities and to more creatively explore funding mechanisms to support those assessments happening. And as I've already mentioned, I think by this point that I feel that it's important that if a person has an FASD evaluation, it's okay if it happens at an FASD Center of Excellence outside of the justice system, but we have to make sure the message around the disability and deficit gets translated back to having that psycholegal relevance that the court and lawyers and professionals like probation officers who are actually helping work with those people to make sure that they understand what the actual interaction is. And so that needs to happen, and those things need to be evidence-based, tailored, and responsive. In criminal justice treatment, really the model, the theoretical approach to helping someone get better and to reduce criminogenic risk factors is called the risk-need responsivity model. It's a pretty old model that has good data that tells us that lots of things that work well are very common sense. The people who are at most risk and have the highest level of needs should have the highest dose of treatment. It should be the most intensive level of treatment. We should make sure that the treatment and management programs that we create for them actually address the needs that they have. And I think most importantly for FASD, and this is what we don't know, is that our approach to treatment matches their capacities. It has to be delivered in a way that they can actually connect with and benefit from. So if we're in jail and we're doing CBT for anger management in a big group setting where they have homework that they need to go back and do in a cell by themselves, I don't know how well that works for anybody. But I'm not clear that it'll work with somebody with an unidentified intellectual kind of disability and trouble concentrating and all of those things. So I think that's really our area of opportunity to frame hanging some of these awesome intervention approaches and supported ways to learning and to treatment is to think about that framework. And then I think we need a lot more research. We need to understand what is the prevalence in corrections, and does that change significantly if we're talking about somewhere up north, or if we're talking about a jail in Toronto, because that's going to inform funding and the approach to managing the disability. We need to have better evidence around screening and diagnosis. We need to know what the trajectories of people look like going through the justice system who have the disability. So we have a really good idea. There are these really well-funded 20, 30, 40-year studies of young offenders and kids who go through the justice system beginning in childhood right through adulthood in the general population, but we don't know what that trajectory actually looks like for this population, or even if there is a trajectory. You know, we don't have any 2 neurobehavioral domains that are ticked off predictively. And so is there a trajectory? If not, let's not waste billions of dollars following folks through justice. Let's then shift money to having an individually sensitive approach that draws from what we know works in corrections, but is addressed to each person's individual set of needs. We need to focus on people's capacities and resilience and know what their needs are. We need to have good, strong program evaluation data to know where we should spend our money and limited resources, and also cost-benefit analyses. So when I, as a clinician, am talking about doing FASD diagnosis and corrections, and it might take me 8 hours to confirm prenatal alcohol exposure, I might not be able to afford to take 8 hours to get all the records and have all the interviews. That just actually might not be a luxury that I have. What happens if I don't do that? That's an empirical question. Does that actually change the services and the care we're able to deliver to that person? Is it really critical? We don't know what the right dose and time spent in an evaluation is yet, and that's a question that data can help us answer. I think one way to answer that, and thankfully it's already been addressed today, is to leverage data sets that already exist. There are at least 300 or 400 adolescent offenders who have been assessed through justice-specific FASD programs in Canada, but busy clinicians, as I can tell you, have a really hard time turning that information from clinical files into usable data. But we can help leverage that by taking those files and bringing researchers in to partner with them. Then we don't have to actually reinvent the wheel and create new data sets. We might have to look at new approaches to screening and diagnosis, using technology, finding different ways of doing things. As I said, finding a balance between being efficient in our assessments and diagnosis, but also having good, helpful impacts for people. We don't have very good understanding of how FASD is experienced or communicated about in the courts. There's a huge literature in forensic mental health and in kind of expert witness testimony and victim testimony. So we know that all the social psychological characteristics and biases that we as people bring into daily lives come into the courtroom. Judges are people and juries are people, and they're making decisions. Lawyers are people and they're making decisions. And we don't actually know how introducing the disability in one way or another influences outcomes. We don't know if it could actually bias decisions in a way that's not helpful, if it's not couched with the right type of information. And we have a lot of good data about that in other areas that I think we could benefit from in FASD to make sure that the disability doesn't end up serving as an aggravating factor inappropriately. So something that actually results in a more punitive or restrictive sentence when that might not be appropriate. And research needs to have a lifespan approach so that we know what's going on with our 40 and 50-year-olds who are still part of the generations of families who are impacted. Having worked in FASD in a few provinces now, and being younger in my career in this area, I am always struck by, everywhere new that I go, how hard it is to know what the lay of the land is in terms of services that are available, programs that are up and running. And I think in all areas, we're not unique in this way. We do a lot of wheel reinventing because we don't know our next door neighbor has already built that wheel like 7 times. And so I do think there's an important call, not only for having provincial strategies. I think of Alberta as really the model of excellence where pretty much in their program, and I'm not going to get into it, there's a clear kind of dictionary and understanding of what's happening, and if you don't know who to call and service connection that's interministerial. But I feel like we really need that nationally so that somebody in Yukon can call somebody in Ontario and say, hey, I want to solve this problem. I heard you solved it. And just take that back rather than spend precious dollars on reinventing whatever that training program is or that intervention is. And I think the factors really that I've talked about today will help contribute to a more sustainable approach to supporting people with a disability towards the ultimate goal of either getting out of the criminal justice system or not getting there in the first place eventually. Criminal justice system involvement comes at an extraordinarily high cost to everybody, to the people in the system themselves, to victims, to families, to communities, to taxpayers. It's exceptionally expensive. I'm sure you've heard the data about supermax prisons and just how much it actually costs in terms of dollars, but also the impact on a person's health and well-being for being in the justice system. So this is a major target that has a lot of really good economic hooks to make this sell. We do not want folks to end up in the justice system because the justice system isn't equipped to understand individualized needs, mental health problems, addiction difficulties, or to address them. However, prevention is really the most important target because it is very difficult and expensive to support somebody's excursion from the criminal justice system. Early data from programs that I've seen around Canada show that even spending a lot of money on very heavily supported programs like the one you guys described are a cost savings relative to how much it costs to prosecute a person for an array of charges that might have happened if they weren't engaged in that programming. And I think that our best combination of effective approaches are going to build on the wisdom we already have, what we're already doing, what we know works both in FASD and outside of FASD, as well as some new approaches that we might have to get ready to kind of try, because we're at the place where we need to serve thousands and thousands of people and the resources just aren't there. It's probably going to be a combination of those things. Some of the exciting projects that we're working on in Hamilton, so please let me know if you've already done this so we don't reinvent any wheels. I'd love to chat with people who are interested in hearing more about this or who are familiar with work that's going on. Thank you. We're actually trying right now to find some funding to develop an adult diagnostic clinic embedded in the forensic psychiatry program at our hospital that will be staffed by forensic clinicians through the healthcare service that will hopefully, as it evolves, actually be able to see people both in the justice system or who are at risk of becoming involved in the justice system to try and help provide some of those specialized evaluations and recommendations and support plans to help get those folks out of trouble. We're also starting to look at some of the work that's happened in pediatric models but hasn't moved into justice or into adulthood, where we're looking at neat kind of screening approaches using eye movement control tracking and EEG monitoring to see if something about those technologies can pick up on people who are in the most need of complicated and more expensive evaluations, because they're the folks who should be triaged for the service. But we can't have really expensive and highly scarce neuropsychologists identifying those people, or no one would ever get evaluated. So we need to find a way that screeners, tools, or technology can help us choose the people who need the highest dose of assessment and treatment in the risk needs responsivity model, and we don't really have any good validated ways of doing that yet. We're trying to do more research soon, I promise. If anybody's heard about the Yukon Corrections Prevalence Study, data release is imminent. So we'll have another sense of really what it looks like in terms of doing the forward-moving case ascertainment studies where we assess everybody to find out what the prevalence of FASD is in a setting. And we're trying to take a look. We really have no idea as to how many folks in adult forensic mental health or mental health settings in general have prenatal alcohol exposure or FASD, but that's really important because it helps us figure out how much time and energy to put into things like tips in forensic mental health and general mental health settings. And that work is easier to do when you work in one, so I'm very grateful for the opportunity to be able to do that. And if anyone else is interested in trying to replicate or be other sites for this work, just absolutely feel free to come and chat with me. I want to acknowledge not FASD-ONE for the work that I presented, but for the opportunity to present here today, because this is exciting to get to share this stuff with you guys. I'm very passionate about it, and to our funders for the different bits of data that I shared with you today. So thank you.